Preset the video using Easdent measure for later use. Research has shown that the distance from the outer cancers of the eyes to the commissure of the lips equals to the distance from the lower border of the septum of the nose to the lower border of the chin when the patient's jaw are in centric relation and VDO. Preset the VDO by measuring with outer edge of the shorter sticks to match the lateral commissure of the eye and the outer edge of the movable handle to line up the commissure of the mouth. When you use the moldable material in Easdent tray later to record the VDO, you will guide the patient to bite down slowly at the centric relation until the outer edge of the shorter stick touching the lower border of the septum of the nose and the inner edge of the movable stick touching the outer border of the chin. The width of the movable stick is 2 mm. Therefore, the bite position is 2 mm less than the preset VDO. This 2 mm room is left for the thickness of the final impression material. If your final impression material is thick, it will raise the VDO a little bit. Thick final impression happens a lot, especially for the beginners. Your final impression thickness may not raise the exact 2 mm for VDO. You can measure what VDO you get after your final impression and let the lab increase or decrease the VDO to what you want. The older patient's corner of the mouth may sag down. The measurement from the outer cancers of the eyes to the commissure of the lips might be more than the patient's VDO. You can reduce a couple millimeters from the measurement as preset VDO. This measurement is a good starting point. It is good for patients with class 1 jaw relationship. However, class 2 patients' mandible are smaller. You can reduce preset VDO a couple of millimeters from the measurement. Class 3 patients' jaw are bigger. You can add several millimeters. You can verify VDO with patient's VDR by measuring from the lower border of the septum of the nose to the lower border of the chin when the patient is at rest. The outer edge of the shorter stick should be 4 mm from the nose at rest. This 4 mm includes 2 mm you leave for the actual final impression thickness and 2 mm freeway space. If the patient has a lot of beard, it is difficult to see where the bottom of the chin is. You have to mark on the tip of the nose and the area without beard on the chin to measure VDR. Use the outer edge of the longer stick and outer edge of the movable handle. Later, guide the patient to bite down at the centric until the inner edge of the longer stick and the inner edge of the movable handle lining up with the two marks. Both sticks are 2 mm wide. This bite position is 4 mm less than the VDR, which has taken away the 2 mm of freeway space and provide extra 2 mm for the final impression thickness. To understand more about VDO and VDR, you can watch the video How to Record Vertical Dimension of Occlusion. If the patient's old denture has severe worn down teeth, you cannot duplicate them, or there's a lot of bone loss, or if the patient has never had dentures, they may have a collapsed bite. In such case, open the VDO become necessary. Typically, 2 to 4 mm of VDO can be safely increased. However, if a larger increase is needed to reach the ideal VDO, it should be done gradually to avoid complications like TMJ discomfort or muscle fatigue. Start by measuring the existing VDO and comparing it to the ideal VDO. If the difference is significant, preset the VDO to a value slightly lower than the ideal, 2 to 3 mm less than the ideal VDO. Each individual can tolerate a different amount of VDO increase, so it is essential to test out with a trial denture to assess the new height. If the patient has difficulty tolerating the new VDO, you can adjust the trial denture by grinding down the teeth to reduce the VDO. Allow the patient to get used to the new height before making further change.